call the meeting to order of the North Broward Hospital District Board of Commissioners Finance Committee. Today is April 18th. Can you take a roll call, please?
Commissioner Fine.
Present.
Commissioner Uri.
Here.
Commissioner Willis.
Here.
And Commissioner Bress. Here.
Okay, pursuant to the agenda, we'll just note additional attendees include the COO, Gino Santorio, CFO, Alan Goldsmith, and General Counsel, Lynn Barrett. Are there any public comments?
Not at this time.
Thank you. So why don't we move to approval of the minutes of the Finance Committee meeting of January 24th, 2018. Is there a motion to that effect?
So moved.
Second. Okay, all in favor?
Aye.
Aye. Any opposed? All right, the motion passes. We're now going to entertain the a report from CFO Alan Goldsmith with regard to the financials. Mr. Goldsmith?
Thank you, Commissioner Klein. I'm going to start off with my finance report. I'm going to kind of give a State of the Union. We've had some changes, and I wanted to kind of give you an update of some personnel changes, if you don't mind. We just hired Ed Mesco. He's going to be in charge of our government programs. This is a very important position. They basically look at our Medicare and Medicaid rates. They work with Diana, who's in government relations, and they're going to kind of work as a team to kind of look at strategies and to work with our lobbyists to kind of put strategies and lobby for strategies that can help us from a financial perspective from CMS and stuff. He comes 20 years experience from Tenet. He's very well seasoned. He's a CPA, and I'm very excited to get him to come work for us. He should start in the next month and a half to 2 months. He's kind of finishing up a special project at Tenet. The next person that I've hired is Romaine Lane. She was at the last board meeting. I don't know if we went quickly, but she's going to be the CFO of Imperial Point. Actually, she's going to be the associate CFO, and she comes from us from North Shore Tenet. She has over 8 years experience in the healthcare industry. She was just recently a controller, and I'm very excited to actually have her come work for us. I think she's going to bring some great insight from the profit world and really help us move the needle at Imperial Point. The next position that I have opened up, and this is all these positions, because I'm definitely finance, have to be budget neutral. So we've kind of shifted around some of our finance folks. Is Jody Halpern. This is one of my, next year, one of my biggest initiatives is MOPED, which is getting people qualified for Medicaid, which is very important, obviously from a funding perspective, but also it allows them to have access points and healthcare access points within the community. So we're really working hard on when they come, looking at the process of getting people qualified for Medicaid, and she's kind of revamping that entire process. So she's kind of doing like a Six Sigma approach, and then she's starting these rev cycle MORs. It's basically kind of like what's going on now is just, you know, where each facility has specific KPIs that are going to be benchmarked against industry standards, and we're going to kind of go through and as a system approach find out why this KPI is down to this KPI from North and Medical Center, and maybe Medical Center has found the secret sauce, and what can we do to leverage the process that we have at Medical Center and bring it to North? Because I'm really trying to create a systematic approach, and in those MORs, it's not going to be just North and me. It's going to be all of us together. We're all going to go as a team, and we're going to talk through processes, and she's going to head that initiative for me next year. So I'm very excited to have her be part of the team. So from a personnel perspective, those are the changes that have happened in my department. I have a very sad news. I don't know if any of you guys know him, but Ken Warner, he's been here for, I don't know, 25, 30 years. He put in his retirement effective 6/30. He decided to retire. So when I first got here, he really helped me through kind of the property tax hearing and the information, and he's been a pillar of Broward Health for several years. So I wish him luck in his retirement. He'll be here through the budget season, or a little bit after. We're trying to keep him on as long as possible because of his knowledge of the budget. And then that's a great lead-in into the budget. So what I've had the systems do, and this is new to Broward, is we're doing quarterly forecast, Q1, Q2, Q3, and now Q4. I haven't brought them to Finance Committee yet because I wanted them to get comfortable with forecasting, because I want you guys as a board and as a finance committee to kind of see where we're going, and I want you guys to hold us accountable to, hey, Alan, you said we were going to be at X, by 6:30, and we're at Y. What happened and what happened? Explain to me. I want you guys to govern the finance process. So I wanted them to get a couple 6 months to 9 months comfortable with the forecast. Because it was a new process for them, and now they're getting better at it. And the Q1 was rocky. Q2 was right on point, and Q3 was even better. So now I feel comfortable to bring these forecasts to these finance meetings. Will be obviously at the end of each quarter. What's nice about the Q4 forecast is the volume and the expenses should be very, very, very similar to what our baseline starting for next year is. So what the advantage of this Q4 forecast is going to do for us is that we can start to think where we want to massage or figure out where we want to put the millage rate for next year. I think we'll have a really good idea where our baseline is. We could put growth in there. We could talk about some of the one-time hits, the ongoing expense reductions that are going to be in there, and we can kind of really, as a team, figure out where you think that we should be for next year. So I'm really excited about to bring this next month. I had planned, I don't know if you guys recall in the last board meeting, I said that I was going to bring it to this finance committee, but since we moved everything up, there just wasn't enough time to get the forecast in, because we needed March to close, which closed a little late this month because of how the days worked out, and there wasn't just enough time for me to get it in, review it, and then feel comfortable to bring it to you guys as a baseline. So I talked to Commissioner Klein, and we're going to bring that to you guys at the next finance committee. Okay, so that's sort of where we're at with the finance forecast and on a go-forward basis. Does anyone have any questions on that?
Thank you. Are there questions? All right, why don't we move on to the financial review?
Okay, so we had another phenomenal month. There is one caveat that we had a ACA settlement that dated back to years ago that we got. It was $1.7 million. We used that money and we accrued the rest of the compensation bonus for the year, and so that's sort of in those numbers, in these numbers right here. So I just wanted to let you guys know that. So on a net loss, we had a net loss of 9.4 versus a budget of 10.2. We're just under $1 million favorable, and then also we were about $600,000 better than prior year. As everyone knows, I'm sure in their 401ks and their personal accounts, we had a rough investment month. That was the February and March were challenging, but we're starting to see hopefully some of that come back. I'm not too concerned about it. If you look at line 17 on a year-to-date basis, we're still up significant to the budget and also from prior year. So that takes care of page 2. If you guys go to PowerPoint presentation slide 3, there's a few things that I want to point out on this slide. If you look at line number 3, overtime and agency as a productive hours, we're at 3.9. But what Gino and I and the team are most proud of is the prior year we were at 5.4% or 27.5%. We're better than prior year. This initiative right here, when you look at it and you can do a comparison, is about $1.5 million savings over 7 months. So this is a significant savings to the organization, and I had promised to this board that I would continuously bring this update to you. Hiring, nursing ratios, and reducing overtime and agency is a hot topic for us, and it's one of our initiatives. And we continue to reduce. So, I continue that to be a hot topic for next year as well. If you look at our margins, which is line 8 from operations, this is the gain and loss, and the gain, we were at 9.7 on a budget of 10.5, and there was a prior year of 10.3. And then on year to date, we're right at budget and 12.8, and from prior year, we're 14.3 or 10% better than prior year. So we're starting to see our margins come back to years from 3 or 4 years ago prior to some of the issues that we had in the last 3 years. Does anyone have any questions?
Alan, I just wanted to ask you to go back to line 3 where you talked about the initiatives to be more efficient, to save money there. Can you elaborate on that a little bit more?
Yeah, so, I don't know if you were here, yeah, I think you were here on the board. We had a big job fair, and we hired, do you remember how many? We hired 150 nurses. But what's really nice about this number is that those nurses, I would say 65% of those nurses, and don't quote me on it, are still in orientation. So we have not even used those nurses to reduce our overtime. This is really just block and tackling tactics of having weekly calls, making it an initiative of ours, and the facilities are really working hard and not using overtime. So this is just block and tackling process.
Yeah, I mean, it's the calls that we have. We started them weekly. We're down to bi-weekly now because really the structure is in. But it's just a matter of flexing based on volume, making sure we have the right staff allocated to the right times, so supply and demand, and just putting an attention back on productivity. We constantly tell them that we want to make sure we have the appropriate nursing ratios. So some of what we've done has actually improved those nursing ratios while still being able to get a lower overtime. So everyone's pretty much focused on that.
Yeah. And we just have, it's not going away. It's every 2 weeks. Gino and I commit our time to it. It's helped us, being newer to the organization, really kind of understand the difficulties that some of the nursing managers are having, and we've been able to support the facilities with hiring or looking at any possible strategies to reduce that delta that we had from our
And what's the goal?
2.5%.
2.5. Is that a national standard?
The balance standard, but yeah, it's a national standard.
Well, that makes it pretty national.
Yeah, it's best practice. 2.5% is best practice. So we want to be a best practice organization, and so that's why every KPI that we look at is always at best practice.
If you could, because this is really important, and I know to everyone here, but in particular myself, in terms of mentioning all for reaching certain financial metrics, all for trying to drive our tax, the need for the public to subsidize our operation, but not at the expense of quality. Okay, and I just want to, if you could just touch on that aspect of things, because and I don't come out of a hospital or healthcare background at all, but there's certainly things, at least from my perspective over the years here, where attention to certain details has both the benefit of improving and enhancing quality and also driving financial metrics in the right direction. So if you guys could address that, because maintaining that quality and improving the quality ultimately, I know is all of our goal, but I just want to make sure we're all on the same page and not at the expense of.
Absolutely. So one of the first things that happens when you take your eye off the ball around overtime is it starts to go up because it's easier to fill the shifts. Then it starts to go up more, and what you run into is you're begging people to come in and work. And what ultimately happens is there's a few individuals generally who are willing to take the overtime. And what happens is they end up working so much overtime, such a disproportionate share of overtime, that you run the risk of burnout and errors, human error. So part of the plan to reduce overtime is to ensure that we afford people the appropriate, breaks that they need in between shifts, so that we don't have some of those avoidable errors that are human errors as the result of burnout. So that's a big component of it. And the other component is, as we're looking at overtime, it forces us to also look at the ratios that we have and the shifts. And while we can reduce some unneeded positions during a particular shift, it also brings to attention where we may need to add positions to a particular shift. So it definitely improves the quality.
What's considered overtime? Over how many hours? 40?
Yes.
an agency too, so another initiative is to reduce agency nurses. They're not part of Broward Health. They're nurses and they do a great job taking care of patients, but we want our people that know our processes and know Broward Health and know our EHR to be taking care of our patients. So, that's a big
They're
part
much
of
more
it.
invested in
Yeah,
good
yeah.
care.
You got it.
And my takeaway from what you were discussing was that the financial and the quality of care go hand in hand, because as you're keeping more of a focus on the financial control, you're keeping the same focus on staffing and resources and making sure that we have the right ratios. So
Yeah,
not only the ratios, but also the type of people that we want who are our own staff.
Yeah, the committed people. I mean, it's not, the incentives aren't always aligned, but in this particular region, they're 100% aligned, so it makes it easy.
All right, well, thank you. Glad to hear that ongoing effort.
The supplies line, is that just because things keep getting more expensive?
Well, the supply line is because, no. If you look at the case mix, we had more acute patients in our hospital. So I'm looking at line 6. It was a Medicare CMI was 1.7 on a budget of 1.7. So generally, when you have sicker patients, you have
More
sicker supply costs, additional costs, as well as additional net revenue as well. So that's a top level indicator that I look at as a hospital operator to determine, okay, the supplies per adjusted patient day is up, but my CMI is up. So then we can go into more detail of where is it up? Is it in this specific supply? We go into much greater detail on a daily basis into that.
Well, I mean, plus though, you got in any 1 month, you can have supplies purchased for cases that are going to be early in the next month, but if you look year to date, you're pretty much on budget.
Yeah, we had a lot of high supply costs, but we had some nice net revenue as well to offset that. So it was high this month, but it wasn't something that alarmed me. As you said, on a year-to-date basis, we're right where we need to be. So does anyone have any more questions on slide 3? Okay.
No? Thank you.
Slide 4 is kind of our statistical overview. We've seen a shift, and this is a shift that we've seen in all different healthcare industries and all the other systems that I've worked at and we've called out. We're seeing a shift from admissions, like inpatient admissions, to short stay cases or observations. We are looking at why this is happening in a very detailed manner by plan, by hospital, by everything that we can look at it from a detailed perspective. We don't know if it's right or wrong, but we want to understand why, so I can articulate into this meeting what's going on and why we see the shift. So I'm not prepared to really give you a detailed answer on it because I don't know it yet. But if you add those together on a year-to-date basis, our total foot traffic, I like to call it, of admissions and observation coming into the hospital are flat to prior year. So although the admission number is down, we're seeing it on the short stay cases. So just so you guys can follow along, line 3, we're down 6%, and then short stay cases, which is line 6, is up 12%. So we just saw a flip-flop, and it's consistent within the market. So we have some utilization comparisons within the local community that kind of have our observation rate as a total admission right in line to the Memorials, the Jacksons, the Tennants, and the HCA. So we're comfortable with it. We just want to understand more about it. Births are up. ED visits are down 3.5%. The data that we look at is, 6 months? 6 months old. It's 6 months old, so we're waiting for the new data to come in so we can kind of look at it in a more detailed manner to kind of figure out why it's down. It may be a good thing that it's down. Maybe the managed care strategies of moving to urgent care and the less acute is taking place. So we're looking at that. And the rest of it is just some ancillary statistics that are there for your reading. If you have any questions.
Now, what's going on with surgeries? I see that's down 6%, year to date down 9% a month. Is there Is there something, are we down any equipment, or is it just a lack of
So
cases?
we in our monthly MORs that we have with the CEOs, we review all the surgeries by service line, and we have seen a decrease in a couple of different service lines. One of them is ophthalmology, which they've really migrated to ambulatory surgery centers. The other one that we've seen is plastic surgery. At 3 of our 4 facilities are down significantly. That was by design. We changed the pricing structure that we had. Frankly, we were not making a margin on what we were doing. So some of that work has been done intentionally. And then the unintentional business that really has migrated out has been orthopedic surgeries. What we have noticed and what the facilities have noticed really is we're down approximately 160 cases in orthopedic surgery. Half of that came during the hurricane. A lot of those cases were not rescheduled. There were only about 19% of the cases that were booked were rescheduled. We've spoken to some of the physicians who have said they just have not seen that. They just lost the volume and never came back. There's a few other things here and there. I mean, there has been physicians that have migrated out of the market. We're working on a strategic plan now to bring in additional physicians. So we still have a net loss there on physicians, which is a component of it. But the other part is, a good chunk of the surgeries that are down are on the inpatient side. And some of them were cases that were unnecessary to be done on an inpatient basis, so they pushed them out to be done on an outpatient basis, and then they just either didn't get done or were handled in a different fashion. So they're down, we're looking at it, we know the specialties, we have a recruitment plan through physician services, and hopefully we get them back up.
Is there a particular hospital that's suffering more
Yeah,
than others
so
in terms of the surgical side?
Yeah, so Imperial Point, for example, is actually up year to date. North is down pretty significantly, and Medical Center is down. North is down almost 12%. Medical Center, I think, was down about 6%. So those two have suffered the most, and in those particular specialties. So North alone, this month, was down 48 cases compared to the budget and last year. And they're about 80 down for the year. So.
How much, if any, of this is attributed to, I guess, some of the, I've just heard from a few physicians and with respect to the efficiency with which the OR is functioning, whether it's scheduling, whether it's, productivity, turning over.
So it's a good question. The patient flow hasn't really changed. So I don't think the loss is attributed to it. I do think that, our main focus now through teletracking, which launches August 6th, is on patient flow. I think we can capture volume that we haven't gotten before due to better patient flow. I think the loss was really due to other factors. I mean, we have a net loss of surgeons, right? We've lost surgeons over the last 3 years. We haven't really recruited them in. We didn't start that recruitment process really until this year. We didn't really start recruiting heavily again.
Well, I guess on that note, where I'm going with that comment is does that type of issue impact either recruiting people or potentially losing people? I won't say who because I don't think it's important, but I was contacted by one surgeon, and this person happened to mention several, I'd say somewhat of a meaningful issue with a case that's supposed to start at a certain time and not just being a little bit late, but being substantially late. Now, obviously, any one case there could be a myriad of reasons why, and of course, I don't know whether or not there's who knows what the issue could possibly be. It could be very easily explained, but when you look at an 8:30 case that doesn't get started until 1, that's not just inconvenient for the surgeon and whomever, it's also very inconvenient for the patient. And having been a patient,
So
I know I wouldn't be happy about
Yeah,
it. So I'm just trying to understand if those types of issues, sometimes they can be fixed with,
Oh yeah.
better management.
So when you look at and that's again part of the reason we're trying to bring in the OR is a component of patient flow improvements that we're doing. So if you look at, we look at on-time starts, we look at room turnover times, we look at percent canceled, and then same day scheduled. So we have not historically had an efficient process at 3 of our 4 facilities in the OR. So we're currently redoing that. We had a discussion about the ORs at North. We are bringing on new OR leadership at Coral Springs. They just made a change about a month ago. It's not an efficient process at all. And it's multifactorial. It's the anesthesia, it's the pre-op checklist that they're supposed to do, the H&Ps not signed ahead of time. They allow for late add-on cases, so they don't have all the data. By the time you get the patient down, then they have to do additional, H&Ps and pre-op checks and consents. So there's a whole process, and as we start to improve that and really utilize the ORs better, we'll have more physicians that are willing to do work there because they may be able to get 10 cases done in a day versus 4 that they may be able to accomplish now. It's definitely a dissatisfier. So, absolutely.
Is there software things that, obviously, just in my business, obviously technology's been a major enhancement of productivity, efficiency, quality, and so on. Is there some element of technology that either we don't have, we have but aren't utilizing effectively, or that we've purchased and are implementing?
So it's a combination of both. The teletracking will help because they have components in there such as the central transport, which is going to help with the transport times to and from the OR. Then there's systems that we already have and don't utilize very well. So we have SurgeonNet, for example, in the ORs. If you go into our ORs and tour them now, you'll still see that we're utilizing whiteboards. So we write on there, this doctor's in this room doing this procedure. It's definitely not the best use of the technology that we already own. And that technology integrates, which will help as well. We had our 6 Sigma black belts go down to medical center last month and do a process flow lean review to see what some of the issues are and come up with a plan to improve it there. And there were many. Some of the physicians are still using paper, even though we have an EMR. So when it doesn't integrate, that adds on time. They're bringing patients down when you don't have some of the consents done, which means that you end up bumping that patient, and now you have to wait another hour because you have to move the next patient up on the list. So there's a couple of really simple things that we can do to fix the OR efficiency, and we're tackling that now. So, we're going to start reporting, once we launch teletracking, all of our patient flow status updates, and you're going to start to see, here's all our current times. As a matter of fact, our CEOs now started asking us for some of the targets, and some of them almost fainted when we sent them to them because we're so far off in some of those areas. But I'm excited about it because we have leadership here who has used it before at the facilities, and they're all begging to be first to use teletracking. So we've kind of pushed up the start cycle of those so we can start getting this stuff done.
You said that teletracking is scheduled for August?
So it's a tiered approach. August 6th is the start date of the Patient Logistics Center, which is the main hub for teletracking, which is going to be in the ISC building across from Medical Center. The week after that is when they roll it out in Medical Center. So we'll have it rolled out there first because they have all of the services. So this way, once we roll it out to, let's say, Imperial Point, if they have to transfer to Medical Center, we already have it set up in Medical Center. This takes care of a lot of the problems. I know some of the board members received a patient complaint just today, and some of it was related to waiting for a bed. Same thing. This tackles that because it tracks all of your wait times from the second you show up to the door to the second you leave. So if something blinks red, you're going to know about it, and you're going to know about it in every single patient flow meeting the next day at 9:30, which then creates that culture of looking at it all the time. There's screens up pretty much everywhere, and that helps to really move things along, so that you don't people don't get left in the cracks.
Who ultimately is in charge of this implementation? Is that through you, or is that through?
So yeah, Alan and I are sharing the responsibility of this one, just because we're both so passionate about it. And then the CEOs, we've really rolled into, some of the balanced scorecards that we'll be reviewing in the future with the board. The drafts that we put on there has an integral part of hitting those balanced metrics that we've set up is successful implementation of the teletracking system and patient flow. So the CEOs are going to own those, and everything, all the incentives are going to be aligned.
So that's going to put in the exact schedule that should be adhered to with each patient, and if it's not, that's when it blinks red.
Yeah, so the perfect example, the best example I can give is an ER patient that comes in and waits, and let's say they're waiting for a CT. They come in, their blood work they need to get blood work and they need to get CT, their abdomen hurts, right? So they want to rule out appendicitis, make sure there's no blood issues. So patient comes in, so the three things they're waiting for is they want to see the doctor, right? So that's one metric that we track right off the bat in our FirstNet platform. The second one is, all right, they had an order put in, right? And we hit the target of 30 minutes. The order was put in within 30 minutes. The next target is to get labs done. The industry best practice we know is 45 minutes. Standard across the country is about 60 minutes, but best practice is our target is 45 minutes. So now we know you have 15 minutes to draw the blood and get it to the lab. So that's a metric we see, 15 minutes. And that's right there on the dashboard. Then when the lab gets it, they know they have 30 minutes to process it and receive and put the results in. Simultaneously, transport's triggered. Transport's best practice is 15 minutes. They have 15 minutes to get down there and pick up patient Jane Doe to get them to the CT. So CT, at that point, if they're met in 15 minutes, now has 45 minutes. 30 minutes to complete the, actually I'm sorry, for CT it's 15 minutes to complete the test, and then 30 minutes for the read and transcription. If any of those targets are off on any of those patients, it's going to throw the average off, and then every single day we're going to have one of those meetings with the departments and say, look, your CT time, so radiology has their own meeting, your CT times yesterday were, your averages were greater than 45 minutes, what happened? Well, these 3 patients were greater, here's why. This one had a PO for contrast. Well, okay, did you order it on time? Yes, but we're using the one that takes twice as long, which I just found out we are doing, by the way. So Imperial Point uses one that's actually cheaper, and the time is about 30 minutes faster, so we're switching the whole system to that. So that's how you start to find where the issues are and correct them so you can hit the best practice.
And then are the patients advised that this is approximately how long you should wait for this, that, and the other thing, so that they're not just sitting there frustrated as can be?
So that's part of lead GESI over quality and the scripting. So that's part of the patient engagement. So the first thing we have to do is set patient expectations. It also helps keep us on task, because if we tell a patient, hey, you need a CT, the expectation is
They'll be at the desk 1 minute after you.
They're going to call you. And they're going to say, hey, it's been 20 minutes. You said 15 minutes. Where's the transporter? So it's a little bit rough in the beginning, but as you start working through it and you see the progress, people really buy into it. So.
Well, it sounds great. Obviously, this is a little divergence from the finance.
He's always
schedule.
stealing my...
I shouldn't have come to this meeting.
But at the same time,
It's
I think
all related.
It is related and extremely helpful. What I was going to suggest is perhaps at the next board meeting, we get another report on the status of the implementation of the teletracking system. And part of that, I think, would be including the training that has to accompany that implementation. I'm sure that's an important aspect of it. So
Yes, it is.
yeah, I would
Absolutely.
suggest that we do that if that's appropriate.
If there's any type of video or visual, like that'd be interesting at least to just sort of see it, not necessarily with a live case, but just what I would assume they have some type of a sample video or tutorial or something to demonstrate the capability.
It would probably be good. We had them come in and do it for our CEOs. A few of them haven't used it before, and it was really useful for them. They were able to understand how it works. We could do that, bring them in and give them 10 minutes and cut them off. I know which ones can give the presentations quick and which ones can't. So we can have them show it to you, because it really helps you to understand how it works. And then,
I think it's a good idea. I think it's, it's good not only for us to see, but for the members of the public to see. It sounds like a very good improvement. Alan, why don't we...
Yeah, so I'll, slide 5 is just how each facility did for the month and then how they did again year to date. I had talked to Commissioner Klein that part of the finance meeting on a rotating schedule. I was going to have each one of the facilities come up, have the CFO come up and kind of present, so you get to see the CFOs, kind of highlight what's going on at their facility. It's going to be on a rotating schedule, so if they do great, it'll be easy for them. If they do bad, then they're going to have to come in and kind of talk to you why they're doing bad. So let them articulate how their hospitals are doing. So we'll start that. I think we talked about having started that next month. We'll pick a facility and we'll have them come and talk to you guys, okay? Slide 6, which is my favorite slide, is the key financial indicators. This kind of is my life from a CFO perspective. Cash on hand is 220 days. The bond proceeds, the $90 million that we took, is not in that number, so that is our true cash on hand that we have right now. A lot of it is the investments that we've had for the year, and a lot of it is also the operating expenses have reduced, and then also the capital has been significantly reduced from a spend perspective, and that was really kind of to help with the culture of Broward, that every dollar that we earn, we need to spend for what's best for the patient and the system as a whole. And I wanted to stop the culture that you're going to get $25 million in capital every year. I want them to get their capital budget. I want them to strategically think what is best for their facility and understand that if they miss on it, it's going to be a miss because they don't have money. There's just not an endless money tree coming to them. They really need to use that capital to reduce expenses, to increase quality, and it was a culture shock for them when I released the capital to them. So, but we did have it as a caveat. If there's additional money that I had allocated to Gino and the team, if it's a patient care issue, there's money for us to have, but it's just not going to be given to you. You need to call us. We need to sit down. We need to do a white paper. We need to understand if we need it. We need to work with procurement to get the best price for it. So that's the culture that I'm changing, and that's why I see a lot of the cash on hand coming back. But I've seen the forecasting of next year's capital budget, and we're going to start to spend some money because we need to replace some equipment and stuff, which is I'm okay with because that's our mission and that's our job. So cash on hand is good.
But on cash on hand, you said it does not include the bond proceeds.
The additional money we took is sitting in an unrestricted cash, kind of, it's not in there.
What about the collateral that we had posted against it? So that's in that 220 days.
Yeah.
But we have received all the collateral back from all that.
Yeah.
It's in there. Okay.
Okay. Probably debt to capitalization is one of our better ratios. Capital spend, as you see, what I was just talking about earlier, we're at 149%, and that's purposely. And then excess margins, profitability, if you look, through March, we're at 3.4%. The Moody's, to get to the A-rated, which is where we're really looking towards, we need to be a 5.6, 6.1. So we're slowly crawling, I like to say, getting back up to the margins that we should be at. Okay.
So just going back, because understanding the bond proceeds are not in the cash on there, are there any other elements of the financial indicators that are like not including these are all well represented. Mm-hmm. So if the 90 days, if the 90 million was included, days cash on hand would be
16 days higher because we spent about 40 of it since we took it, so it'd be about 16 additional days would be added.
Alan, what's going on with the receivable days? Why is that growing?
We had, because of the way that we're classifying Medicaid pending now, we've shifted it around. This is one of the, that's one of the factors, but that's why if you remember, I talked about Jody and doing the revenue cycle, MORs. We need to work on getting our money in quicker. So that's an initiative that we are continuously working on. We're just having slow claims going out there. So
it's not that the payers are paying us slowly, we're working on
It's a
billing
lot.
quicker.
We don't have clean claims. Sometimes we don't have clean claims going out, so they get denied, and then we have to send additional information. I plan on getting that back. One of my initiatives for next year and my strategic initiatives is to get that back to about the 47 days. It's on my radar. It's not one, like 6 days is going to managed care. It's like a couple days here, a couple here days, Medicaid pending. We've taken some disability claims that take a little longer to get in. So they're sitting there, they just keep aging until we get them paid, and then we get them paid in a year, and then the AR days go down.
At what point would you start to get concerned? If it gets much higher than that we have something more going on there, or do you think that this is going to work its way out based on the process you put in place?
I think if it doesn't come down in the next 6 to 7 months when my new strategic initiatives get up and it goes the other way, then I'm going to start to get concerned. I want to let our new process and our new being focused on it play out, and then I want to see, and I'm assuming that it's going to go down just by keeping it as a hypersensitive topic and being looked at on a daily basis. Sort of like with the overtime in agency, if you take your foot off the pedal, it starts to go to every, the to-do list of, down the line. But now that we're looking at it on a monthly basis, weekly basis, I expect that to go down.
What's the lost potential cash earnings from if we were to have 48 days and we were collecting money quicker, so we had more cash coming in at a quicker point? Would it be noticeable in terms of your interest in income expense on our cash holdings, or is it not enough to move the needle yet?
It's not enough to really. If you look, like, it really hasn't gone up from year over year. It's not material of a change at this point. I think if it goes into like the upper fives, like 58, 59, we're going to start to have an issue.
Okay.
So Alan, going back to the rating agency.
I didn't hear you, Chris.
Going back to the rating agency comment, do we have a meeting or any type of a scheduled call? And if not, I know I'm discussed with you as well as previous of your counterparts, the importance of being proactive with rating agencies.
Yeah. So every time we have another good month, I call Beth up, who's one of our, and I say, "You're ready to, I'm ready to have you guys come in, and they want to see us here 12 months, the executive team here 12 months, and we just did. It was kind of weird. We did one like right before I got here, like maybe June. They did one, and then we did another one for the bond. So they did one in like August. So they're ready to do it like maybe in August from this month of this year. They're gonna come back and give us. See what's going on and let us give them an update of where we're at. And if you read the last report, they were very pro what we're doing. They were worried still about the management not being in place and having a temporary CEO, so we've addressed that. They wanted to see that everything that we had told them was coming true, and we've really delivered on that. So I'm hoping that it's gonna go in the right direction when we meet with them again.
Is the accounts receivable gap a big issue in the rating? It's not.
It's really it is, but they're going to look at cash on hand, debt to capitalization, and then they're going to really look at our payer mix and that's what, when we talk to them, that's what they really want to focus. And they've been here a long time. They've been with Broward Health a long time, so they know they've heard a lot. Oh, we're going to do this. We're going to do this, and I think they're just really waiting to see the results that we.
If it really happens.
Yeah. At the end of the day, it's margins, right? If the higher the margins that we give to them, the happier they're going to be. That will help drive the credit rating. So we have a nice story to tell. We had a really rough 3 years, but the last year is a nice story that we can let them know about from a operating perspective. We have a nice story to tell them. We're really doing well in the turnaround. You're starting to see expenses, you're starting to see collaboration, you're starting to see us look as a system, and as a system we win. As a silo, we lose.
And that's exactly what I was going to say, Alan. I think by the time this meeting comes about, I think we'll have a very good presentation and story to tell in terms of the numbers, in terms of the direction, in terms of implementation of new initiatives.
Yeah.
So no one's allowed to leave.
Yeah.
Only forward progress.
Yeah. And the next, I want to skip the other slides are just more informational. I want to skip to slide 10. I think this is a really important slide to kind of tell another story of what we do here. If you look at our charity care, we budgeted 41. We do 26 million through March. Our bad debt is 82. Our community health service, all the access points that we give people to healthcare that are underserved, costs us 22 million, and we're projected to spend 30. The PPUG dollars and providing care for them is 46 million. The tax revenue that we get is only 104. The government funding all in equals to be about 157, and we spend 264. So really, in order to keep this ship afloat and keep due north, we need to come up with $107 million. I know we take a lot of taxpayer support, but we also give a lot to the community. And I think that's a story that gets lost a lot of the times, that we do. I come to work every day and I'm proud to come here because I know that we give the 2/3 people or anybody the best care possible that we can give. And we are, if you look at it, we take a loss on it, and I'm okay with that. I think the loss should be less, and I work tirelessly to get it there. And that's sort of where we're at with that. But I think this is a really important slide for you guys to really look at and dissect, and that's our story. Is we do take taxpayer money, but we give it all back to the taxpayers with care, and I think that's a really great story, and it's something that everybody should be proud of.
I'd like to see this get the publicity it deserves.
I'll second that. I think that's a key point.
And with that, Commissioner Klein, I would like to recommend that you guys call for a motion to accept the interim financials to go on the consent agenda for the board meeting, since we just, I don't know if you guys want to do that, but I would. I can talk again, but I think I can give a little brief, but maybe we put it on the consent agenda for the next meeting.
Well, the agenda for the upcoming board meeting does include acceptance of the financials on the consent agenda. Since the members of this committee are the same as the members of the board for the next meeting, I don't know if there's any action that's required.
It would be, you would vote to put it on the consent agenda, and then you would just approve the whole consent agenda.
I vote to put it on the consent agenda.
Because we have a motion to place
I'll
this on the
second
consent
the
agenda.
motion.
It's been seconded. All in favor?
Aye.
Anyone opposed? Okay, motion carries. This will be placed on the consent agenda. That completes the agenda for the Finance Committee meeting. Entertain a motion to adjourn.
So moved.
All right, thank you.
Aye.